Increased intraocular pressure in a child causes more than optic nerve cupping. It causes changes in a young child, that is. We have changes to the cornea, corneal enlargement, corneal haze, corneal breaks, enlargement of the eye, and refractive error myopia. And when we have a patient who has all of these findings, it's pretty clear that the diagnosis is pediatric glaucoma. But sometimes there are conditions where one or more of these parameters can be abnormal, and these conditions can be mistaken or confused as pediatric glaucoma. How do we differentiate? How do we avoid making mistakes? When we're dealing with pediatric glaucoma, we really have to look at all of these parameters together, and everything together needs to make sense. And we always have to keep in mind conditions that can be mistaken as pediatric glaucoma. Parameters that we look at in pediatric glaucoma, I've listed some of them here. Again, we have to be aware that of these conditions that can be mistaken as pediatric glaucoma. We have to look at the big picture. And I want you to pay attention to one thing that I've done on this slide. I've put measured IOP on the bottom, and I've put it in small font. Because for me, when I'm dealing with a child with pediatric glaucoma, I'm really looking at everything together. And IOP is important, but it's on the bottom of the list, and it's not the end-all, be-all to decide whether or not a child has pediatric glaucoma or if it's progressing. There are reasons why the measurement can be false, and we have to look at the whole picture and not just focus on IOP. Consider this case. It's an 8-month-old girl with unilateral glaucoma. By pneumotonometer and by tonopen, the pressure is higher in the right eye. So let's examine her. The right eye has a higher measured pressure, but the left eye has corneal edema, ophthalmos, -14 refraction, and vertical cupping. So which eye has glaucoma? Obviously, it's the left eye. The point here is we need to look at the whole picture, not focus on intraocular pressure. So I have less than 10 minutes, and in my time, I'm going to go over some conditions that can be mistaken as pediatric glaucoma, because there are abnormalities in some of these parameters that we typically associate with glaucoma in children. Here's a girl referred for glaucoma surgery because of corneal haze and increased intraocular pressure despite drops. Her older sister had surgery for glaucoma, and you can see she has corneal haze, and she also has high measured intraocular pressure. But if this is a child who really had congenital glaucoma, and that's the history, there should be some degree of ocular enlargement, and there's none. And in fact, when we do refraction for her, we can refract her, she's hyperopic. So immediately, this doesn't make sense as a case of glaucoma. When we look at her more carefully, there's corneal haze, but it's a diffuse mosaic haze. The cornea is extremely thick. This is a corneal abnormality. This is congenital hereditary endothelial dystrophy. There's no optic nerve cupping, and the pressure is elevated because the cornea is abnormal. So congenital hereditary endothelial dystrophy, these children have thick corneas, characteristic haze. Sometimes they have high measured IOP and are confused as glaucoma, specific for a particular gene mutation, and they do very well with corneal surgery when indicated, so making the diagnosis is important. Here's a child with corneal haze sent for glaucoma surgery. I don't have pictures of the corneas to show you, but I do have pictures of his face. And when we look at his face, there are some features that are distinct. Further history, the child has had recurrent upper respiratory infections, has joint laxity. This child has a mucopolysaccharidosis, and it's glycoaminoglycan deposition in the cornea that is causing the corneal haze and a falsely elevated intraocular pressure. Now, these patients are tricky because they can truly develop glaucoma, but in the early stages, it's deposition of the glycoaminoglycan in the cornea that causes the haze and falsely elevated IOP. These patients are around. They often go misdiagnosed for a long time. Ophthalmologists are key in picking them up. They often have characteristic facial features. Corneal clouding is an early manifestation in several of the subtypes. And it's non-trivial to pick these patients up because for certain subtypes, there are now enzyme replacement therapies, an important diagnosis to be aware of. Here's a baby referred for glaucoma surgery. you can see why glaucoma was considered. The corneas are very large. He's got borderline myopia, he's got borderline cupping, he's got borderline IOPs. How do we decide whether or not this is truly glaucoma or some kind of ocular malformation? Well, something that I've found very helpful in cases like this is to do an axial length, because in anterior megophthalmos or megalocornea, the ratio of the anterior chamber length to the ratio of the total anterior axial length is usually greater than 0.19 or 0.2, whereas in true buphthalmos, you don't have that ratio. And so when we do that, you can see he's got a very high AC depth to axial length ratio. This doesn't happen in glaucoma, but it happens in anterior megophthalmos megalocornea. He's got maternal male cousins who have similar findings. This child has X-linked megalocornea, does not have glaucoma. This is due to a specific gene mutation. They can develop glaucoma as adults. They still need to be followed, but they don't develop childhood glaucoma. Comparing the AC depth to the total axial length is very useful in these kind of situations. Here's a 6-month-old with large corneas and large cups referred for glaucoma surgery. It's not showing up very well, but you can even see a nerve fiber layer defect in the left eye. Looks very much like glaucoma, but what else do we see in this child? This child has a small head, large corneas, but a small head. Actually, she has microcephaly. Not only that, she has periventricular leukomalacia, which is something we see sometimes in premature infants. Periventricular leukomalacia is associated with a form of optic nerve hypoplasia that manifests as cupping. This child has a hyperopic refraction, the pressures are not high, she's been stable for many years. She doesn't have glaucoma, she has megalocornea and optic nerve cup enlargement from periventricular leukomalacia. Again, this is something that is seen in premature infants. This optic nerve hypoplasia looks like glaucomatous cupping. They actually do have visual field defects, but they're static. And always consider this diagnosis in any child who is premature and is suspected of having glaucomatous cupping. Here's another child, 5-year-old, referred as glaucoma suspect, certainly has large cups. But not only that, take a look at the optic nerve compared to the fovea. These are also large discs. This patient has megalopapillae. Children with large discs have large cups, but the disc rim area is the same. This is a congenital abnormality that is sometimes confused with congenital glaucoma. It's a static thing, it's a normal finding. The last case that I would like to share with you is actually not a pseudoglaucoma. This is a true glaucoma. This child had unilateral glaucoma in the right eye and sensory exotropia. No tricks here. This is glaucoma. Glaucomatous cupping in the right eye, not in the left eye. We did trabeculectomy for her at the time, and we had a terrific response. The pressure went down to 16 without drops, and she did very well. There was even reversal of cupping, which we sometimes see in pediatric glaucomas when we lower the pressure. But the child actually was a complete treatment failure. Why? Because the child had severe induced myopia in the right eye and never wore the glasses or never patched. So the most important point I'd like to make is that in children with glaucoma and with pseudoglaucoma, amblyopia management refraction is critical because you can have excellent anatomical results, excellent IOP results, but if we don't prescribe these preverbal children with the proper glasses and patching, they will have poor vision, and it's actually treatment failure even though the disc looks great. So to conclude, elevated IOP, corneal haze, large corneas, disc cupping are not exclusive signs of pediatric glaucoma. We have to look at all examination parameters together when we make a diagnosis, and this all should make sense because there are conditions lurking out there that can mimic pediatric glaucoma. In my experience, the two most common conditions misdiagnosed as pediatric glaucoma are CHED and periventricular leukomalacia-associated optic disc cupping. And my final and most important point is untreated amblyopia is the #1 cause for visual loss, both in pediatric glaucoma and in pseudoglaucoma. Cycloplegic refraction is critical, not only in diagnosis, not only in treatment, but also in diagnosis. Thank you.